Ladies and gentlemen, it's a real pleasure to return to Firenze and to give you the introduction that has applications to orthopedic surgeons and physicians. And it's so wonderful, I think, to bring together the disciplines. I'm a rheumatologist and epidemiologist, and we should have more of these interactions. Our secondary fracture prevention services entail the interaction on the shop floor, as we call it, but I think to discuss the problems academically is really great. So congratulations on AutoMed, and of course it's wonderful to return to the city. So Capture the Fracture grew out of a working group that we established in the International Osteoporosis Foundation, which divides into national societies, science, and corporate colleagues. And in the science, we had a series of about 8 or 10 working groups within which fracture management was one. And very rapidly it became apparent that one of the global issues was how to undertake secondary fracture prevention. And we undertook a systematic review of the available strategies and then constructed the Capture the Fracture initiative. And it is basically a global campaign for prevention of fractures by implementation of fracture liaison services. And I will say a little bit about how the template has been established, and then I look forward to hearing about the 3 examples that we have in the session to follow. So the background is very simple, I hardly need to stress it. You all know that fragility fractures are common in the United Kingdom and sort of Europe-wide. 1 in 3 women, 1 in 5 men over the age of 50. They affect quality of life and they're costly. And the current best estimate for European costs is 32 billion euros a year, and in the United States, 20 billion US dollars a year. The components of fracture liaison services are that they need to identify patients, they need to evaluate risk factors for osteoporosis and for falls, they need to initiate osteoporosis treatment where appropriate and fall prevention strategies, and they need to ensure adherence to that therapy. And of course, you're well aware that it is an integration, sometimes in secondary care, sometimes in primary care, sometimes a hybrid, and depends upon the individual coordinator. So the objectives of the program that we established about 3 years ago were to set standards, and I'll show you the basis of the best practice framework, how we evaluate showcase centers, and then illustrate them on the website. To facilitate change, so we are beginning a mentorship program, and we provide free implementation guides and toolkits that I'll show you examples of, that explain to people, particularly when they're starting off in practice, the business case, the framework within which they can set up a secondary fracture prevention service. And then to raise awareness, disseminate free resources, communicate to communities, and gather support from a coalition of partners. So the first thing, the setting of standards, that depended on the construction of a best practice framework, which was then used worldwide to evaluate the performance of different secondary prevention schemes. And the 4 steps involved in that can all be accessed through the website. You as a centre submit a questionnaire that's electronic and very simple, 5-point scales about the fracture prevention service that you've set up. You then, by pressing the button to send that questionnaire in, enter on a map marked green while that centre is being reviewed. The questionnaire is reviewed, and I'll show you the benchmarks, the 13 standards against which the questionnaire is set. 2 people review it. There's then a discussion with a country representative that knows the nation, so in the case of Italy it would be Maria Luisa, and then a level is assigned by initially private discussion with yourself as the investigator or centre coordinator. And it's only once you've agreed that the benchmarking had been done properly, your questionnaire had been understood, etc., that there's a score and an assignment of gold, silver, or bronze, which is then recognised on the map. And when we first started out, we had no idea whether anybody would be interested in this or not. We now have a huge backlog of questionnaires, and as I'll show you, representation from around the world, because people find that this has been useful to leverage funding for their own fracture liaison services. So, the 13 standards, which were set up from a Delphi group that was established within the working group, are about patient identification and evaluation, post-fracture assessment timing, presence of vertebral fracture recognition, assessment guidelines, secondary osteoporosis, fall prevention services being available, multidisciplinary assessment, allied health professionals together with physicians and surgeons, initiation of medication, review of medication, communication strategy, long-term follow-up, and maintenance of a database. And for each of these, there are 3 tiers, bronze, silver, or gold, of recognition. So say for patient identification, if you identify but don't track, that's bronze. Identify and track is the silver, and identify, track, and review is the gold. For medication initiation, 50% of patients, the bronze, 70% silver, and 90% the gold. And then, from the 13 standards, there's a breakdown into 5 categories. So, hip fracture strategies, inpatient and outpatient-based systems, vertebral fracture strategies, and organization as a whole. And basically, you can reduce all of the questionnaire-based information to one single score, just for simplicity. So, as I said, with a start only a couple of years ago, 128 FLSs are now registered on the map. They range from Algeria to the United States. You are clearly represented here. 77 have had completed review, and 51 are in the system already. And of the 77, 30 were gold, 33 silver, and 44 were bronze. Let's look at some of the characteristics, because it is interesting, even though we would think of one model, maybe, a fracture liaison nurse, outside our fracture clinic, linkage to our osteoporosis service, our bone density scanner, and then a letter to our GP or primary sector. These are huge, these are hugely different. So, patient population varies from 100,000 to 1.3 million. Mixtures of private and publicly funded hospitals, and the range of fracture patients from 180 to over 6,000. When you look across the ratings in the 5 categories, there's a pretty consistent relationship of bronze, silver, and gold for hip, inpatient, outpatient, and organizational. But there's clearly underperformance of vertebral. So we are basically setting up efficient systems for non-spine fractures, but we have not yet captured that big proportion of spine fractures in postmenopausal osteoporotic fractures for secondary prevention. That's clearly something that we need to focus on. And the orthopods among you will be happy to see that orthopedically based FLSs predominate amongst the different single specialties. And then from within internal medicine, endocrine, geriatric, rheumatology are pretty well the major components of medicine. Across the world regions, we've got more information on Europe, North America, Latin America than on Asia Pacific, Middle East and Africa, and Australia. But between the nations that we have got, there tends to be a greater preponderance of gold and silver grades in, as you would expect, the European and North American gradings. Now I just want to pause for a couple of minutes and talk to you about the evidence that fracture liaison services work. Because one of the things that's very important when you set these up is not to imagine that the evidence base is complete and the critics who will be weighing up different financial allocations will accept your assertion that fracture liaison services must work. So in the UK, even though the government actually insisted on placing fracture liaison services within the NHS contract, there was no cluster randomized trial that demonstrated that having the system reduced fractures compared to not having the system. And that was something we got a Health Services Research grant for, Kasim Javed, Andy Judge, and our team in Oxford and Southampton. And we have, in this whole area of Britain, which is south and central, we have 4,000 hip fractures a year and 12,500 non-hip fragility fractures. And we looked over a period of 12 years. These data are in press in Age and Aging, and there have been a couple of other publications in OI and in the geriatric literature. We looked over 12 years at what happened to 1-year mortality, 30-day mortality, and second hip fractures. And we related those to when each of these areas, if I go back one, when each of these areas introduced a fracture liaison service. And what we found was that there was a dramatic effect of both the nurse and the orthogeriatrician on mortality following hip fracture. But because in this first look, the main fractures that were identified were inpatient fractures, we didn't show a second hip fracture reduction. And so we're going on with this evaluation to look at outpatient fracture liaison services to try and see these reductions. The other parts of the evidence base to be aware of are the Kaiser Permanente database in California, where over a period of 15 years there's been increasing use of DEXA, increasing use of osteoporosis drugs, and reduction in fracture. And the Concord study in Australia, where again there's observational evidence for benefits from this. The other point that this study of ours showed is the huge excess cost of the second hip fracture. If the first hip fracture costs about 8,000, the second hip fracture costs 14,000. It is a hugely more expensive fracture. So just in closing, why should you all join? Well, really, to showcase the achievements, to leverage further funding, to share best practice with colleagues, and to become part of this sort of global initiative. Anybody with a coordinator-based system of care can participate at any stage in development and at any size worldwide. The translations of the framework include Italian and range from Chinese, Japanese to, we're just undertaking Arabic. There's a slide kit and toolkit which is available off of the website or from IOF head office, completely for free. We can just send that to you. And the toolkit includes not just the need for it, the implementation guide, but also, importantly, a business planning process, which we have found highly sought after. And that business planning template looks something like this and provides you with just a few places where you add in your own information, but you then have the rationale to present to your payers. 3 strikes and I'm out, or 2 strikes and I'm out? 2 strikes. Other resources, national audits and surveys are available, and the long-term goals are to spread knowledge of this through a webinar program. We've just completed the 4th of these on how to implement, and we've received funding from our corporate partners to extend this to nation-specific efforts, and I would hope that your country might become one of those. There's a mentorship program to sort of sponsor shared training approaches for the fracture liaison nurses and the champions in each of the areas. And there's hopefully now a grant program in which we might be able to join a sponsor to provide financial support to facilitate the implementation of FLSs. Just remains for me to acknowledge the help of all of the members of the steering committee, all of our country champions, of which Maria Luisa is our important one for the country of Italy, and all of our sponsors. And once again, to thank you very much for your invitation back to Firenze, and to wish you really well with AutoMed 11 to 20. Thank you.
And Cyrus, this presentation is open for discussion.